Okay, I'm going to try and do a little Camtasia relay and go back into that neurogenic pulmonary edema lecture that we were talking about, and pulmonary embolus, if I can find it. And hopefully I'm recording, and let me make that a little bigger. Let's start there. We're talking about the fact that this pulmonary embolism is going to increase pulmonary vascular resistance. This right ventricle is the weaker of the two ventricles, and it's really not going to be able to keep up. So as it fails, we had the concept that the right ventricle is going to become distended as fluid backs up from the pulmonary artery. The right atrium is going to be distended. We're going to get all these signs of right-sided heart failure like JVD, hepatojugular reflex. And as that right ventricle becomes dilated, and as blood is not able to go from the right side through the pulmonary artery because of the blockage, there's less blood that will enter the left ventricle. So we've got reduced blood flow from right to left. So preload, which is one of the factors that's critical for cardiac output, is going to be decreased in the left ventricle. The other thing is, you can see that as the left ventricle becomes distended, the right ventricle becomes distended, it's going to shift the interventricular septum to the other side, and that's also going to prevent that left ventricle from filling. So there are lots of things that are going to affect cardiac output also from the left side of the heart. It's not just the right side that's the problem. Since blood pressure is going to drop when cardiac output drops, our baroreceptors are going to receive this low blood pressure signal. We're going to release catecholamines like epinephrine, for instance. We're going to get vasoconstriction that's going to try to increase our blood pressure. So cardiac output goes down, peripherally we vasoconstrict. It's going to try to bring blood pressure back up. But again, if you don't have good blood flow through the system, it's really not going to be a winner. We're asking this right ventricle to work harder than it ever has before, and there's, particularly in an elderly population with coronary artery disease, we might not get good blood flow to the heart muscle. So it's another one of those failure scenarios where we're asking the right ventricle to increase its workload, but it may not have the capacity to do that. So the right ventricle gets ischemic, in other words, doesn't receive enough blood flow, and it's going to fail. So it's just a vicious cycle that starts with pulmonary embolism. If you have atelectasis, this is probably because we've reduced blood flow to those type 2 cells. Remember, we're plugging off the pulmonary capillary bed, which is supplying blood to the alveoli. Type 2 cells are the ones that make surfactant, and if they can't function anymore, you're going to have alveolar collapse. You're going to, because of loss of surfactant, and you might also have death of tissue, pulmonary infarction, and you'll get alveolar hemorrhage from that. As Brian was talking about in class, and as you saw in your chapter, if you have a saddle PE, that's going to block the whole pulmonary artery. Patients are going to die from pulseless electrical activity. For instance, in this example, we've got a saddle PE, so one leg, the right pulmonary artery leg, is filled with clot. The left pulmonary artery leg is filled with clot. You can see that we still have filling defects in other parts of the vessels, and if we marched farther and farther through this, we may see a lot of stringy clot. Now it does look like we do have some blood flow, because this is contrast material. Looks like there must be some blood flow getting through, and again, otherwise this patient wouldn't survive the CT scan if it was completely obstructing the pulmonary artery. We're going to have lots of problems with VQ mismatch, and since your patient's got, let's begin with shunting, or excuse me, let's begin with dead space. The first problem that we've got with a clot, we're going to have ventilation without perfusion. So we've got alveoli that do not eliminate carbon dioxide. So you've got to increase minute ventilation overall in order to maintain alveolar ventilation, because a large amount of your ventilation is going to go to dead space. On top of that, we've got somebody who is going to have all those compensatory mechanisms that are going to cause low VQ and potentially shunt. Hypoxia is also going to stimulate those peripheral chemoreceptors, the carotid bodies, and if you have a drop in PO2 below 60, for sure that's going to happen. It's going to get made worse if for some reason we're acidotic and have high CO2. So these patients are really going to have a high drive to breathe. Initially, these people are going to hyperventilate, but again, the diaphragm is going to get tired, ventilatory muscles are going to get tired, they are potentially going to fail and have to go on mechanical ventilation. When we're looking to try to identify if in fact we've got pulmonary embolism, one of the studies, the blood value is the D-dimer. D-dimers are going to indicate increased breakdown of fibrin degradation or fibrin degradation products, increased breakdown of clot. So when you've got a hypercoagulable state with clot that's being formed, remember it's also being broken down. So as they're broken down, these D-dimer values go up. So that points to the possibility of pulmonary embolus. The other thing, if you go back to cardio and look at VD to VT ratio, if we've got ventilation without perfusion, that value should increase. So I want you to go back to cardio and go back to remember what's the equation and the raw values we'd have to calculate a VD to VT ratio. When you couple the D-dimer value that's increased with a high dead space to tidal volume ratio, the sensitivity of those two combined to identifying pulmonary embolism is really very good. And we said chest x-ray may be normal. So chest x-rays aren't very helpful, and really neither are electrocardiograms. There are some changes in ECGs that are consistent with pulmonary emboli, but some of those also can be due to hyperkalemia, for instance, when potassium goes out of whack. So that's not terribly reliable. In the past, the gold standard used to be a pulmonary arteriogram, where they would get a catheter in the pulmonary artery and inject dye, and then they would identify what blood vessels were being obstructed. That's really a pretty invasive procedure. So they started doing nuclear medicine scans where they would look at ventilation, where patients would breathe in a radioactive gas and see what parts of the lung the gas went to, and then they would inject a radioactive tagged albumin and see where the albumin went. And then the radiologist would look to see, okay, I've got ventilation in all of these lobes, but I don't have perfusion in all of these lobes. So if I'm not perfusing those with blood, then I probably have pulmonary embolus. Well, that is fairly reliable as long as you don't have a disease state like emphysema. So really, the helical CT scans are now the gold standard for diagnosing these. There are some that can generate very, very small slices, and they have very, very good ability to pick up on these pulmonary emboli. If we treat these patients, and remember this course is not really about treatment, we may give thrombolytics, and we talked about in class this breaks up clots. Unfortunately, if you give a thrombolytic, you may also cause bleeding in your patients, so they may die from hemorrhage even though they've survived their embolus. There's a catheter, a variety of catheters that might be used to do an embolectomy, so they can actually go in and snatch that embolus and pull it out of the pulmonary artery. They're also doing embolectomies for, like for instance, if my mother was younger when she threw her clot and had her stroke, they may actually be able to go and do an embolectomy in the cerebral artery and unplug it. She wasn't a candidate. Cardiovascular support, obviously, patients have to have an adequate blood pressure. So we're looking at things like infusing volume, giving oxygen, probably giving an inotropic agent to help the heart pump more strongly against all this resistance. But really the thing that we have to do is prevent these clots. So that's why we're getting patients out of bed very shortly after surgery. Anticoagulants like heparin are being used. if patients are no longer hospitalized, they may use Coumadin because patients can take Coumadin at home. But the problem with Coumadin is you have to go in and check INR to make sure that they're in a therapeutic range. There's actually a new anticoagulant, and its name escapes me, that does not have to have those frequent checks. So that might be a new drug that we see used more. Leg squeezers, SCDs, sequential compression devices, I believe is what SCD stands for, or even the old TED hose, you know, the tight stockings. They may be able to be used to prevent these emboli, or excuse me, thrombi from forming. Certainly the thrombus may form and become an embolus, but we'd rather not have the thrombus form at all. And then IVC filters are something that may be used in patients, especially when they can't be on anticoagulants. They use an IVC filter when there's a known thrombus to prevent it from going to the pulmonary artery. So if you look at an IVC filter, there are a variety of these, but they look like kind of an upside down bird nest. So this is in the inferior vena cava, and if a clot forms and it goes up into this filter, it should get trapped. So let's see if we can get this link to work.
Boston Scientific is recalling certain vena cava filter systems. The recalled devices are small cone-shaped filters used to help prevent pulmonary embolism. The filters are implanted in the inferior vena cava to capture blood clots before they're carried to the lungs.
The devices are being recalled because in a small number of cases, a certain part of the filter's delivery system has become detached while the device was being implanted. And this has led to reports of patient injuries and one patient death. Now, it's important to note that this recall applies only to devices that have not yet been implanted in patients.
The recall affects the stainless steel Greenfield vena cava filters with 12 French femoral introducer systems manufactured before March 10, 2004. These devices have a use before date of March 2007. For instructions on how to return any unused devices covered by this recall, contact Boston Scientific at 888-272-1001.
Now, when you look at the rest of the links that are on the right-hand side, there's actually one in expert filter removal at Stanford. These things can be placed temporarily, and then when the risk of embolization goes down, those things can be removed. So that is pretty handy to know. And that's the end of this show. So I hope this has been helpful. We'll see you next week.